This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, #She's on Call. Please welcome our hosts.
Hi, I'm Dr. Sujana Chandrasekhar. I'm an ENT surgeon. I practice in New York and New Jersey, and I'm really happy to bring you our third episode of She's on Call today. My co-host, Dr. Marina Kurian, is a bariatric surgeon in New York City. And of course, as computers would have it, we had a computer glitch about 30 seconds ago, so she'll join us as soon as she's able. Today, we have two wonderful guests, Dr. Jordana Cohen from University of Pennsylvania, Penn Health, and Dr. Olga Garcia from Community Memorial Health System in Ventura, California. Dr. Cohen is an epidemiologist and a nephrologist or kidney specialist, and she's an amazing clinician researcher. Dr. Garcia is a general surgery resident. She's going to be going into a colorectal fellowship, and she's a second lieutenant in the U.S. Air Force. We're very pleased to have them both on with us today. Please hit like and share and subscribe to us. You can see us on Facebook, on YouTube, on Twitter. You can follow us at LinkedIn and Instagram. We're very grateful to Scroll.in for carrying us on their platform and allowing a really world of viewers to watch us. We're going to be covering a host. Hey, Marina, you're here.
We'll see how long this lasts. Wi-Fi, man. The world runs on Wi-Fi.
It's amazing. So we're going to cover a host of topics, and please like, share, subscribe, all that stuff. Please tell your friends. We really have a lot of fun talking with each other and answering your questions. And maybe, Marina, we can jump right into the news.
Okay. Well, I mean, what haven't we talked about? You know, we were just on the read-along. We talked about how some certain states have really had tremendous upticks, and you know it's going to be great because one of our guests is coming in from California, and the other guest is an incredible scientist and she's not really an epidemiologist, but she's a statistician. She's wonderful, and we can ask them about it. But so you know, Arizona's having a huge uptick. We had our guest on last week. Houston's having, and Texas is having a lot of increases, and California. So we are looking at what the different states are doing in terms of social distancing, mandating masks and not mandating masks. And so a lot of what we're going to discuss is really about that. And then, of course, as I pointed out earlier when I was on the read-along, that you know our governor, New Jersey, New York, and Connecticut have instituted a travel ban or a self-imposed quarantine for people coming from 9 states. So Alabama, Arizona, North Carolina, South Carolina, Texas, Florida, and I didn't mention Florida before, but Miami is seeing a tremendous number of cases as well, and then California.
Yeah, so we're seeing caseloads increase, daily cases of 4,000 and 5,000. And this graphic is from NPR. And what you see is the darker the orange is, the more increase in caseload recently. So you're seeing that the south and west of our country is really bursting with cases, while much of the Northeast, which was sort of the first epicenter, I mean, we lost 45,000 lives in New York and New Jersey. I mean, that's crazy, out of 125,000 deaths in our country. So we are getting better up here. The problem is around the world. So we're seeing this increase in cases in Brazil, in India, in the United Kingdom. But, we paint those countries with a single brush. And I think, Marina, you had shared with me some information about a particular state in India that's doing incredibly well.
Happens to be the state where, I'm from, Kerala. Although arguably I'm from New York, right? So, so the health minister in Kerala has been really aggressive in terms of contact tracing and quarantining people that have been infected. And so the state is really, it's been noticed around the world how well that they've done in terms of outbreaks, and just the way that she's handled it. And she has every county within the state really following the same regimen. And so that has really impacted their rate of infection with COVID, so much so that, hopefully the rest of India takes notice and they start doing the same. And I think the incredible thing I learned from reading the article was just on CNN, was that the contact tracing was so important. And that's something that we are doing now, but we still don't have enough contact tracers. So it's a little bit harder. I feel like that's why in some degree that we're in the States, we're a little bit behind that in terms of contact tracing. But obviously the social distancing, mask wearing, washing hands, all really good to flatten the curve. I can't wait to not say flatten the curve.
I know. I can't wait till people don't remember what that means anymore. Everybody knows what that means. But, Dara Cass, who was one of our first guests, talked about testing, tracing, and isolation. And we're not doing enough testing in the United States. Our contact tracing is just starting, and it's not as effective as we're seeing in Kerala, in Germany, in New Zealand. Like, we're just seeing other places really do a much better job. And this isolation, we're asking people to self-quarantine when they come from other states. Nobody needs to show papers to come from another state. And one of my patients who just came up from Florida 2 weeks ago, self-quarantined, said, how would they know? I have New York plates, right? So it's very hard to gauge that. We've been following these guidelines for over 100 days, the social distancing, the masks, the hand washing. We have a couple of graphics on the correct way to wear a mask. This is a Twitter feed from Professor Vishal Mishra at Columbia. And he just looked at what would happen in the states that did not mandate masks if they did mandate masks. And you can see that the red graph that goes straight up in terms of number of cases is in states where masks are not mandated, whereas the curve would in fact be flat or blue if the states did mandate masks.
I think that's such an incredible graphic, right? So the red is what's actually happening, and the blue is what would have happened if they had just said, wear a dang mask. Wear the mask. How hard is that? And I think that's so important. I think people should really note that this could be our most important takeaway from our show, is that if you wore a mask, that this explosion of cases in all the hard hit areas would not be happening.
So, when you wear a mask, you have to wear it properly. So I'm just going to do a little tutorial for people who don't know.
Yeah, she's an ENT, so we're going to follow what she said.
So here's a mask. This happens to be a surgical mask. There's a top and a bottom, which is the top has this metal band on it, and the bottom does not. There's an outside, which is blue, and an inside, which is white. The way you put this on is you put it on, hook it over your ears, and you pinch over your nose the metal strap. You pull it over the bridge of your nose and under your chin. If it's loose on the sides, you can actually twist this and put it over your ears to make that tight. What you want is an airtight seal. When you remove your mask, remove it like this. Don't touch the inside or the outside, and hang it somewhere to dry. One of my friends asked me if they could microwave this surgical mask. You could if you want to start a fire in your microwave. So don't do that.
No, but people were talking about how you could put it in the oven at like 140 degrees. And no, even healthcare professionals. So it seems that certain masks, you can do that and get away with it, and you don't see smoking or deterioration of the mask. And this was really going on when we had so many PPE shortages, and they were like, use your mask for the week. If you see it break down, then you'll get a new one. I mean, that's pretty dramatic. So you want to kind of try and sterilize it if you can. And so that's where this whole temperature thing came up. But certain masks you cannot put in the oven or the microwave.
Yeah, and you can frankly just hang these up to dry and they're fine unless they're soiled. If you have a cloth mask and it keeps slipping down, you can actually put a pipe cleaner, our old, pipe cleaner from elementary school, arts and crafts, and screw that into your mask, and that'll act as a pinch. And then, of course, the cloth mask can be washed in hot water. We have a number of questions that many of our readers have asked, and we really appreciate it. Please like and share and subscribe and tell your friends and send in questions. Good morning. We're gonna, I have I'm gonna do a self-plug. I have a bunch of videos about COVID that I thought were outdated that I made in March and April, and they're certainly not outdated because we're still in that first wave. Yeah. So you can find them on my YouTube channel, which is Dr. Sujana, which is my first name, Sujana, and you can just look at them and laugh at me, but you might learn some tips. But I think the other questions we can actually ask with our guests. So maybe Marina, you want to bring our guests on?
Yeah, so first I will invite Dr. Jordana Cohen. She's an assistant professor of medicine and nephrology at University of Pennsylvania. So thank you so much for joining us, Jordy. And then Dr. Olga Garcia is chief resident out in, I want to say it's Ojai and Ventura, right, in California. And she's also a second lieutenant in the Air Force. So it's going to be great to get a couple of perspectives, both from, the hospital from Olga, but also like what's happening in the military. It'd be wonderful. Thank you so much for joining us, you guys.
We're really glad to have you. We're really happy to have you. We have Ermin Hero watching from Finland. We have Mark Lee watching from North Carolina. We have people watching from New Jersey. We have Alamelu Iyengar watching from Northern California. We've got people watching from India. We're very grateful that Scroll.in is broadcasting us on their channels. This is, as you know, a global pandemic. We want to talk about, hello, Delisa, my friend from Nicaragua. I do medical missions, or when I could travel, I did medical missions in Nicaragua. And it's a beautiful country with beautiful people, and unfortunately facing a huge explosion in cases with lack of PPE. So we are not out of the woods. I know that Jordy and Olga, we want to talk about your subspecialties, but we also want to talk about your take on COVID.
I want to ask. We should answer. We mentioned Mark Lee. Like he had a question about what we're going to do now that it's fireworks season, and also you're going to see, all these social gatherings of more than 10 people or 25 people. And so, what are we going to see in terms of COVID and also firework injuries, right?
Right. So, I'm going to jump in just because my friend Ben Chang, who's at University of Pennsylvania, does hand and microsurgery. And he texted me Thursday. He said, please make this PSA on your show. We are seeing so many fireworks injuries. People are just blowing off fireworks every night all over the place. And because many of the big shows with professionals are canceled, people are taking it upon themselves to use fireworks. He just took care of somebody who blew off both of their hands. And he's an amazing reattachment surgeon. That person is left with one finger on one hand and two on the other and no thumbs. So this is not a joke. When I see firework injuries as an ENT, I see people blowing them off near their ear, and they give themselves permanent hearing loss. So firework injuries, we're going into the summer. Please enjoy the summer, and please don't do stupid things. I wonder, Olga, if you have some experience with some of the things people are doing in your area that are either good or bad.
Yeah, I have heard the fireworks going off for the last couple of weeks, all around us, really. And I think in this particular area, I would definitely caution anyone to participate in those things because there's such a high risk of wildfires. It's been really dry, and we've already had around 5 fires locally that, required a lot of resources to put out. So and the fire season is just beginning, so it's very worrisome. But certainly, personal injuries are not desirable either.
Yeah, that is such an important other fact, right? Because California, you guys, not only forest fires or shrub fires, right? You also have mudslides and all these other things that we don't really think about as in New York City area, but critical to really add to the fireworks safety protocol, because forest fires and those shrub fires can be so devastating and especially where you are, Olga. Like, was it just last year or was it 2 years ago? I mean, it was, fires burning all around Ventura, Ojai, everywhere. It was just an encroaching, and so much land was burned, and I'm sure it's not recovered yet.
Yeah, that was, I think it was 2 years ago in December, the Thomas fire happened, and, lots of people were evacuated, lots of people lost their homes and all their personal belongings. So it was a big deal.
So maybe, Jordy, we can talk about some other things people are doing. I don't know if you're aware, the FDA just released an advisory against sort of these cut rate or low cost hand sanitizers that have methanol in them instead of ethyl alcohol. And I wonder if you can talk as an internist, as a nephrologist, and as somebody who understands statistics really well, what people should be worried about if they're buying these sort of cut rate or off-brand hand sanitizers. There's a particular company called Eskion. I think we're going to have the link to it, to the FDA advisory, but maybe you can talk to us about what they should be concerned about.
Yeah, thank you. That's right. Very, very close to home for me. I've dialyzed off more methanol toxicities than I would like to say. And so something that I think is really important for people to be aware of is we know methanol is toxic. And we know, for instance, we always think of it as people drinking moonshine, where they think that it's ethanol, but there is methanol in it. 12 to 24 hours later, they end up blind and presenting to an emergency room with nausea and vomiting and with mania is sort of the typical presentation we're used to. What I think most people aren't aware of is that you can actually get methanol toxicity from absorption. And so several hand sanitizers, if they're not created in the correct capacity, they're prone to the similar issues as moonshine in terms of distilling alcohol and ethanol. You can have a higher proportion of methanol than you would want in more than any methanol in hand sanitizers can result in toxicity through absorption. And so it's very important to be careful and to make sure that you know where you're obtaining your hand sanitizers from.
So this particular company, this Esk Biochem, which is a Mexican company, was warned by the FDA, but has not pulled their products. And I'm very concerned. Marina and I were talking earlier today, and all the hand sanitizers are getting sold out again. And so you want to make sure that you could take a screenshot of this. You go to the FDA website. They have this advisory. Please don't buy these products, because you would think, yeah, you have to drink it or you have to inhale it, but you actually just on your skin, right, Jordy? Is that what you're saying?
Yep, you can get it through absorption. You can get methanol toxicity, and it's the same methanol toxicity that you would see with people drinking it.
Wow.
It breaks down to formaldehyde and formic acid, and those can result in irreversible blindness and this and other negative effects that you would have from formaldehyde and formic acid in your body. It has to be dialyzed off to correct these issues within 12 to 24 hours. And if you do not get urgent dialysis and fomepizole in that time, then the damage is often permanent.
We hear a lot about dialysis, and we hear a lot about dialysis with COVID-19. I wonder if you could step back and just try to explain to our audience what that means. What is dialysis? How do you do it? Simple, but maybe something we all need to understand better.
Yeah, with pleasure. I'll give a sort of a brief lay explanation of what dialysis is. And so I'm a nephrologist by trade. So I'm a kidney doctor, and I also create research studies and interpret data related to both kidney disease and high blood pressure. Dialysis is a major aspect of what I do. Dialysis is a procedure that is done to clean the blood when somebody's kidneys aren't working, and it replaces the function of the kidney. Your kidneys have two very critical roles. One is to remove important toxins from your body, and this is really the only time that I approve of people using the term toxins, because often that term is misused in the press, and so really only in the concept of removing them for dialysis is when we approve of that term. And the other purpose of dialysis is to remove fluid from your body, because as we all know, our kidneys produce urine, and they're the reason that we are able to get a lot of the fluid off of our body by urinating. And when your kidneys no longer function or are in failure, you cannot produce enough high quality or quantity urine. And so dialysis takes over that task and helps to remove extra fluid as well. And so in COVID-19 patients, and in many severe diseases, but more so in COVID-19, we see people when they're very, very sick because your kidneys are very prone to shock and they can stop working as a result of many infections, but we think more so in COVID-19 for several reasons, because there's higher risk of clotting, there's higher risks of very severe immune responses in COVID-19 that the kidneys are particularly sensitive to. And so we end up seeing that a lot of patients have to receive a special type of dialysis who have COVID-19, which is a gentle, continuous dialysis, where we're not just giving people a usual dialysis, which is typically a short procedure that's done through the bloodstream, where somebody has a large IV placed either in their neck or in their groin, and we do a procedure for about typically 4 hours, about 3 times a week. Instead, in COVID-19 and what we see in very, very severe and scary illnesses is we do something that's a continuous dialysis. It's much gentler on the body, but it's an indicator that somebody is much more critically ill when we have to do that. And something unique to COVID-19 also that we're seeing with this dialysis is that, first of all, we had a lot of shortages for quite a period of time, especially during the surges in New York, where we couldn't get a lot of the materials and a lot of the fluids we need to adequately perform dialysis. So even when patients would have normally been able to be treated with it, we were sharing devices across patients and not giving them the usual level that we would normally want to be giving them because we were so short on materials. But then also on top of that, we were on top of that, the devices just weren't working. They're clotting off. There are a lot of other issues that are very unique to COVID and creates very, very big challenges in adequately treating people. It's very scary. Yep.
Yeah, you brought up that there were shortages in terms of getting resources, right? The things that you actually need for the dialysis. But what I've also heard is from some of my colleagues that a lot of their patients that were getting routine dialysis for whatever reason, they couldn't get in, and they actually lost a bunch of their patients. So can we talk about, we talk with COVID about if you're immunosuppressed, if you're elderly, you're looking at the high risk groups, but dialysis patients have a lot of chronic issues that actually can severely impact their resilience and their ability to rebound from an illness.
We're running into huge problems here still. My dialysis patients often can't get to our dialysis shift and are not getting their usual level of dialysis because they can't get rides. The drivers it's very hard to find people to transport people to dialysis right now because the dialysis patients are at risk of being exposed constantly because they're always in a healthcare facility, and also the drivers are often not exposed or at risk because they're driving a lot of patients, and so we're having great problems with getting people adequately dialyzed, and there have been many patients I'm sure that we'll learn more about throughout the country, but by anecdote I've heard about many cases where people have passed because they can't get to dialysis. We had one person who asked to stop dialysis because they would rather take the risk of dying from not having kidney function than the risk of dying from COVID. And I've heard of several other situations similar to that.
Yeah. Olga, I want to ask you, what's happening in California in terms of COVID? Are you guys seeing the uptick, or is it just are we just seeing that in like the bigger cities? What's exactly happening? How far are you away from like LA or San Fran, that kind of thing? I'm terrible at geography, by the way. So everyone else is like, hello, Ohio. Like really?
Well, I think Olga got lost a little bit. I think she went off to where you were. So I think maybe, hi Olga, you're back.
Hey, Olga, I was just asking what you're seeing out in Ojai and Ventura, and I was just really admitting that I'm horrible at geography. I mean, other than that, I know the states on the coast, and I know where Texas is. So Texas, you guys listening, I know where you are, but the rest of it, I'm a little shady on. So, but what are you seeing in terms of what's coming into the hospital now? I felt like, because I'm very good friends with one of Olga's attendings or teachers, but I'd seen a lot of the posts talking about going in during COVID. But now you guys are on such an uptick. What are you experiencing?
Yeah, so in the spring, when California locked down fairly early, we did really well overall. Our numbers were low, even though we prepared for, the big spike, it never really happened. And so as we started reopening over the last, month and a half or so, things slowly started building. And, in the last couple of weeks, it's definitely progressed to the point where now our county, Ventura County, is on the governor's watch list again for potentially phasing back the opening and the operation of all the different businesses. So we'll have to see what happens. We're definitely seeing a lot more positive tests and a lot more people hospitalized, including in the ICU, including the young people. As a general surgery resident, I am not necessarily intimately involved with their care. But from our standpoint, we have seen a lot more, perforated appendicitis, a lot more terrible gallbladders and bowel diseases like diverticulitis that people just, they waited a little bit too long before coming into the ED and seeking care because they're afraid, which is understandable.
Yeah, but I think that's a great PSA, right? Letting people know that if you're feeling pain, call your doctor, let them know, get in earlier. I think all of the hospital systems have done a great job of trying to limit where the COVID patients are and trying to protect patients that are coming in for other things. Are you doing elective surgery right now, Olga?
We are. As far as I know, we're even doing screening colonoscopies and endoscopies at this point. But, things change week to week, and, our administration is kind of making those decisions as new data and information arrive.
Yeah, and so in addition to seeing more complicated disease, it makes it a lot harder, right, for us to do the surgeries in a nice, minimally invasive, small incision manner. And sometimes when the disease is so bad, you actually have to open, and there's also greater risk of other infections or it involving a greater area than it would if it was just an early appendicitis or an early gallbladder attack or infection. So those are really considerations. I think if people are watching, and you're having issues, you have to get seen earlier. And sometimes you can treat with antibiotics and other times you can't. So you can't necessarily stave it off. You likely will require surgery, but it's important to get out there and let your doctor know that what's going on. And I think certainly in New York, most of the physicians are back to work. There was a time when some of my patients would be like, my doctor's office is closed. I'm like, really? Because your surgeon is open, like I'm going to see patients. So, and that's not an indictment against the other doctors. It's just the way that they have to work. And so what are you seeing also in California? Do you see that the doctor's offices are open now as well? They must be if they're doing screening colonoscopies and endoscopies.
Yeah, as far as I know, everyone's operating at full speed. I just visited the dentist myself. They're taking precautions. They're asking screening questions. They're taking your temperature when you come in. So I think life is going back to normal, despite what seems to be happening with the numbers and the positive tests.
So, I'd like everyone watching and certainly, tag your friends. We have @She's on Call on YouTube, Facebook, LinkedIn, and I think Twitter, and then also #She's on Call. Actually, probably is on Twitter. So just share with your friends. We're happy to have Jordy and Olga with us, and we've been talking a lot about COVID. Sujana, do you want to branch in and
Sure. Sure. So we actually are having viewers chime in from Sri Lanka, from Maryland, from Tallahassee, Florida, from California. I love this comment by Ellen Austin. Marina must be a New Yorker because, you know, so am I. And our teachers just told us the world ends at the Hudson River. And I remember one of my favorite graphic art presentations was New York as the center of the world, and then the Hudson River, and then sort of everything else. And we had to take it upon ourselves, you know, I mean, in this time, we're taking it upon ourselves to educate ourselves about many things. You know, Jordy, we've been talking, and I think we've all been talking about the delay in healthcare. We saw it in New York for heart attacks, for strokes, for appendicitis. You know, what Olga was saying was if you can get in early, and Marina echoed it with abdominal pain, maybe you don't need such a drastic intervention. But, you know, at some point, dialysis is done and patients are ready for a transplant. And I think, you know, we hear about that as lay people from, you know, TV shows, from, you know, dramatizations, but maybe you can talk to us about what the process is about thinking about getting, for example, a kidney transplant.
Yeah, it's a good question, especially right now, because it's really potentially life-saving in many patients, and especially eventually many patients can't be on dialysis forever, and there's a high risk of death on dialysis, and it's really life-saving. There's no question about it to get a transplant, but at a time like this, it's scary because transplant patients have to take medications that suppress their immune systems in order to prevent rejection from their transplants. And those medications, in turn, make them much more prone to bad outcomes from COVID. And we've seen some very scary cases of horrible outcomes in transplant patients from COVID. But if they were to not take those immune suppressing medications, they also, I mean, they need them to also save their life. And so it's a very, very tough situation for people with transplant. My father-in-law has a kidney transplant and has been on lockdown since March, and we don't let him leave the house. And it's a very challenging situation also for people waiting for transplants right now, because there's always been a huge supply and demand problem for people who need transplants of any organ. And right now, really, it's very challenging because you can't give somebody an organ from somebody who has coronavirus. There had been, especially early on, delays in testing, and it would take quite some time to be able to get results back that by the time you would know if a potential donor, a deceased donor, had coronavirus, it would be too late to donate the organs. And so there are a lot of challenges surrounding organ transplant right now, and the rates of transplant have gone down drastically, which is really sad. It's important that they've had to. There's really no other choice. But really, right now, many transplant surgeons throughout the country have only been willing to transplant organs into patients that they know will be well enough to be able to withstand a coronavirus infection if they do get one, and also in situations where they can be confident that they're not providing organs that have coronavirus. So it's creating a bigger supply and demand problem than there ever was previously, which means that people who are on wait lists are going to be waiting longer, unfortunately. And so we're working very hard to come up with solutions to these problems and trying to streamline donation and choosing people very quickly who are appropriate donors. But there are huge logistical challenges around that.
It's so interesting, right? Because, you know, you think I went for the antibody test. I mean, of course, I had early on, I had the swab down the nose, like really deep. That was uncomfortable, right? And then I went for the antibody test as well, and I'm negative. And what I was, you know, kind of secretly hoping that I had antibodies, because we feel like they should be protective if we understand what our immune systems are doing. However, they're also saying maybe they're not protective. We don't know. And so the intriguing part when you're talking about the transplant is if someone was exposed and they have antibodies, does that mean that there's COVID, you know, virus lurking in the tissue, or does the antibody, is it protective? I mean, there's so many unanswered questions, which is kind of terrible, mainly because of the expanse of penetration of this virus across the world.
Yeah.
You know, we're getting some very interesting questions and comments. J.H. Kim is saying that the country, in fact, begins west of the Hudson. So clearly, J.H. Kim, you are wrong.
I think she lives in California. It's cool. It's cool,
Yeah,
man. I know where California
but,
is.
there are minimal openings, right? So the dentists in the New York, New Jersey area have retrofitted their offices with big HVAC systems to cleanse the rooms and lots of PPE. We have some physical therapists open and some not yet across the country. We have some, beauty salons, barber shops open, some massage therapists open, some not. So I think part of it is we're not seeing sort of a clear explanation or clear guidance that's unified from the top. I mean, we are seeing it from Dr. Fauci, who is leading the task force, but we're really not seeing it broadly dispersed among the politicians who can really guide restaurants, other facilities of what to do. I think one of the things that people are still concerned about is, how do you wear a mask? So we keep getting these questions, and maybe I'm going to just shoot it out to, maybe we'll do Olga and then we'll do Jordy, and we'll do Olga and we'll do Jordy. So here's the CDC guideline on how to wear a mask. So cover your nose, cover your chin. It's not to be worn over your neck or under your nose with your nose sticking out, or above your mouth with your mouth sticking out. So, the first question, do masks work? And I'm going to answer that. Yeah, they protect other people from you if you are an asymptomatic carrier. And maybe, Olga, I'm going to ask you, do masks deplete your oxygen?
They do not. So as someone who wears a mask all day, pretty much every day, in the operating room, I've never had any issues. I'm standing up, operating. I've never passed out, anything like that. So, now we're wearing them around the hospital at all times, and I still take the stairs, and it's a non-issue. So I think that's a very unfortunate myth that's been circulating around the media, and we have to put an end to it.
And then I'm going to ask Jordy, maybe you can talk to our viewers about the difference between a surgical mask, a cloth mask, and an N95. Because people are very confused about what to wear and who wears what.
Yeah, it's a good point. And so they're all designed for different purposes. And N95 has some very, very cool technology behind it that allows it to block out 95% of particles that would go through it. That's why it's called N95. And it's really they really need to be preserved for healthcare providers and people who are most exposed to aerosolized virus, because there's a huge nationwide shortage of them. There's going to continue to be a huge worldwide shortage of them because very few machines can actually make them in the world. And the purpose for those is to protect the people who are going to be most exposed, who you need to be around to save you when you get the virus. And so those really have to be preserved for healthcare workers. Surgical masks are the next best thing. They are high quality in terms of preventing any particles from leaving from your mouth to go outside, but they don't protect you from other things coming in and affecting you. But they are quite effective in terms of protecting other people around you from getting any kind of infectious particles from the person wearing them. That's why surgeons have worn them for decades. As you are all surgeons, more not myself, but that's why we wear them in sterile procedures. That's why masks have been shown tried and true in many circumstances to prevent infection very, very effectively. Cloth masks aren't as good, depending on the type of material. They're much more prone to being porous. But when everyone wears them, it still prevents infection substantially. And there's a paper that had come out a couple of months ago that had demonstrated this. If you have people where somebody has it and both the person who's not infected and the person who is infected both are wearing a cloth mask, you still have a much lower risk of infecting each other, about a 2% risk of infecting each other. Both are wearing masks, even if it's just cloth masks. And so they do really make a difference. It's just not going to be as good, of course, as wearing these higher quality masks, but every bit counts a huge amount, especially on a population level. And the other thing to keep in mind too, by the way, the N95 masks, a lot of people have the ones with valves that they wear that had been used for protecting people from dust particles, for instance, when cleaning houses, so that when you breathe out, Particles can come out of your mouth, but it protects you from having particles come in. Those are not good. Those should not be worn because all you're doing by wearing that is protecting yourself from dust particles and potentially making other people at risk of catching your coronavirus.
This is a video that Nina Shapiro, who is an otolaryngologist at UCLA, put on her Twitter feed. And this is somebody literally blowing a candle through one of those N95s with the valve. So this does not protect the person around you. Alamelu Iyengar, who is in Northern California, asks, is it true that N95 masks only protect the person wearing them and not the person around them? And Marina, maybe you can take that question.
Yeah, sure. So what this video is showing that those masks with the valve on it are mostly used by construction. And one of my colleagues, also a healthcare professional, he has one of those. A super gave it to him. So those are masks that are more for preventing dust particles. If you're doing, work and using the saw or something like that, all those things that can become aerosolized and inhaled, it's going to stop you from doing that, but it allows you to breathe out so it's not as uncomfortable. The true N95 does not have that valve, and you are not going to be able to blow that out. And that is a slightly better mask in terms of not infecting people around you. So I guess that's the answer. If you're using an N95 that fits you, right? So I've had a lot of my colleagues who are very petite, don't have as big a head as me, I guess, and they're like, those N95s don't work. And they have to find a PPE that's actually working for them and for the shape of their face so that it will actually fit and form. So an N95, when you breathe out, you shouldn't feel it come up by your eyes or out underneath your chin. So it's a more complicated process. But if you're just saying in the main, if you're wearing a mask like that, which has that valve, you're not going to be as protected if you're sick. And if you're sick, don't wear your mask and go outside. Stay home. You're sick. Stay home. When it's hard.
That's called quarantine. That's a good thing. Just isolate yourself. Joe Diamond, who's a cardiologist in Queens, writes that the politicization, I said all of those vowels and consonants in a row, of masks is really disturbing. It is really disturbing. I completely agree with Joe. Wearing a mask or not wearing a mask is not a political statement. Wearing a mask means you care about your community and you don't wish to infect people around you. Not wearing a mask kind of says the opposite.
KN95s, what do you think of those? I've actually got, I have one. I didn't realize that they were so different, but they are very different than a K95 that we get at the, or an N95, excuse me, at the hospital. So the KN is just a thicker material than like a regular surgical mask, and it seems to have a couple of different layers, but it is not as fitting as a N95. And I don't know in terms of, it's supposed to be the 95, as Jordy said, is, getting out 95, not allowing 95% of the particles in. So if they have that label, then that should be what's happening. But I think what it is also is that, as I said, when you breathe out with those, you should not feel it coming up through the eyes and the sides. But I don't know if anyone else has any more info on KN95. Jordy or Sujana?
I think the Medical Society of the State of New York mailed us all KN95s, and they don't fit as tight as the N95s. The N95s leave a mark at the end of the day. Like, you get this very attractive crease around your face right here. The KN95s fit a little less snug. In the operating room on Thursday, I actually wore a KN95 and a surgical mask for a patient who was tested and is COVID negative. So I think I felt that was enough. But they're the true N95s that are in fact fit. We used to have to go for respirator fitting once a year, make the most sense.
Jordan, you were going to say something about the KN?
Just that it's not the same technology from my understanding. The N95 is just this very unique material that has, it's a magnetic effect of the plastic that actually attracts particles to stick to it to prevent them from transferring. And I'm pretty sure the KN95s are a different type of material. So while they're still helpful and better than a surgical mask, I agree with you, it's not that exact full ability to prevent transmission in the same way, and they're not fitted, as you said. So from my understanding, it's sort of a midway between an N95 and a surgical mask.
Olga, what as a reservist, I've understood from some of our colleagues that they're not doing a lot of the normal weekend activities that a reservist would do. What's happening in terms of, if you can share anything about what your reserve units are doing and what's been coming down through sort of the military aspect and how they're dealing with COVID and their recommendations, because that's such a huge part of our country. And we have so many reservists and also active duty members. It'd be nice to hear what's happening there.
Mm-hmm. So unfortunately, I won't be able to answer your question entirely because I'm a medical reservist. So I don't actually participate in any sort of, weekend training. I essentially am just focused on completing residency, and then I'll be doing active duty after I finish my fellowship. So I'm kind of distanced right now from that world, but I did speak to someone this week who's stationed in Italy, and there was a travel ban within the military as well, and so all of those men and women overseas, they were unable to come back, and that was indefinite at one point, but now they are bringing them back to the States. So it seems like there is some progress that's being made, thankfully.
So the medical doctors, I have had some of my residents and fellows end up going out back into active duty from reserve. So it is one of those things that when the people are out in Italy and in the station there or around the country, come July 1st or August 1st, you're starting a fellowship or you're starting, that's sort of when our year starts and ends. And so travel bans can really impact, moving on to another step. And it matters for so many. And also people just in regular jobs, if you're planning on changing a job and now you're, stuck at home. I've heard from many, many people in finance and corporate America that have been able to do their jobs from home online, that they're not even planning on going back till January. And I have to assume that that's because everyone feels like vaccine time in January. And what are you guys' thoughts about that? Someone said to me that they think that healthcare workers are going to get the vaccine first. And I'm like, okay, normally I'd be like, really? I don't know. I think people whose insurances will pay or whatever. But in this case, I was like, yeah, okay, yes, I will take the vaccine first.
I'm curious what vaccine. I know Brazil's already announced that they're producing 1.3 million vaccines by X date, and I'm curious what vaccine. I know Fauci made a statement optimistically saying, "I hope we have one by January," and that's where I anything Fauci says, I agree with.
We love Fauci.
Yeah, exactly. There's so many under development, but we're still really are just in the early stages of understanding the immunologic function of this disease and whether even a vaccine would even create a permanent solution. And if the vaccine could potentially have other immune side effects, or that the disease could have an adverse reaction after you get it. So it's going to be a prolonged process to really know until we have a vaccine in place. And I really hope we have something by January, but I'm not optimistic. I think this is going to go similarly as how dengue vaccines have gone, just because they may behave similarly in terms of the viruses, but we don't know.
So we have people chiming in, saying hello from Delaware. Suchi Iyengar says, what about summer camps? Down in Delaware, they're keeping summer camps open for kids. We have a lot of people whose children are planning to either go back or go to college for the first time in the fall. What do you, and Julia Week says, Olga, my partner, is a captain and medical planner in the U.S. Army, so maybe Army-Navy games could ensue. And thank you for your service, and we do thank you very much for your service. We've all worked in the Veterans Health Administration as part of our training and often as part of our careers, and it is an honor to take care of people who serve our country as you are. But I'm wondering, what you think. Maybe we'll start with Olga. What do you think about opening up day camps or sleepaway camps for kids?
That's a tough question. You know, it seems like we hadn't seen much virus transmission among the pediatric population or illness for that matter. But should we be using them as guinea pigs, so to speak? Perhaps not. I know probably those of us who are parents need some reprieve from being at home and entertaining the kids all the time. But I think it's too soon to really tell how this is going to affect the population.
You know, and I think it's of great concern when they come home and maybe grandma lives with you, or maybe they're, you know, they leave summer camp or they leave day camp and then they spend the next few hours with grandma before they come home, or grandpa, or a parent who has an immune compromise. So Jordy, what advice might you give? I mean, you're in Philly, so you're, you know, Delaware is your suburb, right? So what's your advice for people?
Delaware's a state, dude. It's not a suburb.
It's totally a
That's just so funny. Philly rules Delaware. Oh my.
I will say a ton of my patients come from Delaware, so I think of it kind of as a Philly suburb. But yeah, I've been asked this a lot, and especially among my immunocompromised patients. Do you send your kids to summer camp? And it's a tough decision because we do think that there's probably a little bit of a lower risk of spread outside, so that if they're outside all of the time, maybe it's a bit safer, but I still think there are problems. I think a lot of it comes down to the fact that we don't see the disease as bad in kids, if at all. There are very few cases. When it does happen, it's devastating. But what we see is a lot of disparities in terms of who's getting sicker, and it's people who are living in closer households. People who've got multiple generations in one household are the groups of patients that we're seeing the worst disease and the biggest spread in. Black patients tend to have multiple generations in one household. They tend to have closer knit families, and we think that that's part of why more grandmas and Black families are coming in and dying from this disease. We also think that might be what happened in Italy. There are several epidemiologic theories that the reason that in Italy it rose so quickly and the spread was so severe initially was because of so many more multi-generational families living together. So I think that the places that shut down schools quickly were smart. I think the places that are making plans now to continue either doing school remotely or having very carefully socially distanced teaching in the fall are also wise. And I think flexibility is going to be key because we just aren't going to be able to predict what this next surge will look like.
So you do think there's going to be a surge, Jordy, and also, you know, you're at Penn. You know, you have Penn, right? And you guys are going to start in the fall. Different strategies, right? Keeping the kids straight through November or through the Thanksgiving, and then allowing the kids to come home, and then doing remote learning for a couple of weeks. I know my daughter's college is going to do that. So those are all important changes. It's also to protect the faculty, not just the students. You know, and then there's this little bit of info coming out that age over 20, you're slightly more risk than age under 20. So I got one kid over 20 and the other one 18. So I'm thinking, oh, but what's happening? It's complicated.
Yeah.
So, you know, you mentioned healthcare disparities. There's my picture. There you go, everybody. Clearly, New York, the Hudson River, a bunch of land, and then the Pacific Ocean. You know, we mentioned healthcare disparities, and I think that's the elephant in the room in many ways, not just for COVID, but certainly highlighted during COVID. And Dr. Tom Frieden has a really beautiful blog, and he talked about healthcare disparities with Native Americans, non-Hispanic African Americans, and non-white Hispanics having the three highest incidences of not just getting COVID, but of getting severe disease requiring hospitalization, intubation, having the poorest outcomes. So I think that this is a matter that all physicians and healthcare providers are taking seriously, and it's something we really have to look at. We have just a couple of minutes left, so maybe I can ask you guys for top 3 of what each of you think people should know about your field? And maybe we'll start with Olga. What are the top 3 important things that patients or people should know about general surgery and maybe colorectal surgery?
Sure. Yeah. So one of the things that we always talk with patients about is colorectal cancer screening. And it's really important because we are able to find colorectal polyps and actually remove them entirely before they ever have a chance of developing into a cancer. So, some of the other screening tests are not as good because even if we do identify a problem, like there's blood in the stool that's microscopic, we still have to do a colonoscopy to actually identify the source of it. So if you just get a colonoscopy, then you can be done within a day and kind of put your mind at ease.
And Olga, what's the age? What age should people get colonoscopy?
So in general, we recommend 50 years old as a starting age for screening colonoscopies. But if there's any family history of colorectal cancer, then it should be done earlier, depending on when your relative was diagnosed.
Jordy, any final thoughts before we go to our credits?
Yeah, just your kidneys are the source of high blood pressure. They're often the source of a lot of heart disease. So just don't forget the importance of them. If you have high blood pressure, if you have other medical issues, make sure you're still following with your primary care doctor during this time, because so many people are putting aside these other chronic issues as though they're not important as COVID. And this is what we're worried about, is what if the second or third or fourth surge is going to be more people coming in with heart attacks, coming in with kidney failure, who weren't seeking out the chronic care that they needed.
Thanks, Jordy. I want to thank all of you guys who are watching. Please do share. Again, we have @She'sOnCall and our hashtag is She'sOnCall on Twitter. But share with your friends. This is something that we're going to do weekly. And of course, I want to thank our producers for the show, and also want to thank Scroll In for sharing our show with their viewership. They are one of the largest organizations, actually now worldwide, right? But in India as well. And it's a news organization, and they've been able to share our show with their viewership. So I want to thank them. And we're on July 5th. You want to give a shout out, Suju, to what we're doing July 5th?
Right. So July 5th, which is Independence Day weekend, we are going to do a best of. So we won't be live, but we'll be having some highlights from our 3 She's on Call shows and our 2 shows that were hosted by our co-executive producer, Sri Srinivasan, to kind of give you guys a flavor of all the things we have talked about. On July 12th, we'll be back live, Sunday, July 12th, 11 a.m. to 12 noon Eastern Time. And we will be very pleased to have Dr. Quinn Capers, cardiologist and big proponent of understanding diversity and understanding implicit bias in medicine and surgery, and Dr. Sushmita Pati, who is at Stony Brook, and she is a pediatrician who runs their primary care pediatrics and is also the medical consultant for the Alan Alda Institute of Communicating, so about teaching others about things. And speaking of teaching others, Irma Chavez from Alexandria, Virginia writes, please tell people COVID-19 is real. Yes, people, COVID-19 is real. Please wash your hands, maintain social distance, wear a mask so we can see each other in person. The 4 of us, instead of staring at our computers, could actually be having a cup of tea. And that's going to happen when we all take this disease seriously.
Yeah, thanks again, everyone who's watching. Jordy, one of the comments is they love your Millennium Falcon in the background. I didn't even notice it. I was like, oh my God. I see it now. That's wonderful.
You're going to be on tape. The recording is going to be available right after this is over. So if you liked our show and you feel like somebody else needs to watch it, please tag them and let them know, and share and like and follow and all those words that I keep getting confused about social media. We are so very proud of our colleagues, Dr. Jordana Cohen, Dr. Olga Garcia, for everything that you're doing. Keep up the good work, and we'll see each other in person soon. Have a great week, everybody.
All right. Bye, everyone.
Thank you.
Bye.